It's U of L Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome to U of L Today with Mark Hebert on 93.9 The Ville. Hope you had a good July 4th last week and hope everything is going well for all of you who are U of L fans and paying attention to all the great stuff going on at the University of Louisville, because that's what we do here on the show. Tell you about all that good stuff going on at U of L. So on the show today, the opioid crisis and the resulting increase in drug overdose deaths has prompted the state to ask for help with handling autopsies, and U of L is stepping in to do just that. But first, there are a couple different kinds of heart pacemakers, one much more expensive than the other. U of L's Rakesh Gopinathannair is the director of cardiac electrophysiology in the School of Medicine, and he's been studying these pacemakers to figure out which ones are the most cost-effective for heart patients, and he's going to tell us a little bit more about pacemakers in general. So, Rakesh, first of all, let me try your name one more time.
Sure.
Gopinathannair.
Yep.
Is that right?
Gopinathannair, yeah.
Ah, very good. I was close. I didn't have the emphasis on the last syllable. Got it now. All right. Let's talk a little bit about what you do at the University of Louisville.
So by profession, I'm a cardiologist, and I specialize in a subspecialty of cardiology called electrophysiology. Electrophysiology is a study of heart rhythm disorders, and as you know, heart is as much a muscle as it has electrical. So it needs electricity to pump, basically.
So you're an electrician?
I'm a heart electrician. Let's put. So along with heart disease, a lot of people get rhythm abnormalities. They can be very slow rhythms, like your heart rate must be like in the 20s, or you won't have a heartbeat for several seconds. And then there are rhythms that go super fast. Can be, you'll be 70 beats at one moment and you'll be 200 beats the next, so there are several reasons for that. One of the all of us have a natural pacemaker that we are born with. It kind of sits in the right upper chamber of the heart, but as time goes, it can get diseased and get slower, and which can make you super tired, dizzy, lightheaded, no energy, all those kind of stuff. And in certain scenarios, you need to support the heart rhythm by a device, and that's where the pacemakers come in.
And there are different kinds of pacemakers, right?
Correct. Yeah, but pacemakers basically, it's been around for few decades. The initial ones were done in the late 50s, early 60s.
Late 50s, the pacemakers
yeah,
been
but
around.
Those were kind of very sort of crude, and
they were big old clunky things, weren't they?
Initially they were put in the belly, and the battery only lasted a few hours, and so on and so forth. Nowadays we have it only a little bigger than a quarter, so it is the pacemaker part, which sits on it's usually somewhere in the left or right chest, and there are a couple of wires that go into the heart, which is threaded through a vein that runs just under the collarbone and empties into the heart, and then these wires basically sends electrical signals from the heart and working with the pacemaker. The pacemaker basically has a battery, and it has circuitry that tells the wires what to do. It's all and they are very programmable. You can set multiple rates, all those. It's a complicated device, but it just does a great job in keeping you. So basically, what a pacemaker does for somebody with slow heart rhythm is that it keeps them in
keeps you in rhythm.
Yeah, and then prevents them from. It gives them energy, gives them prevents them from passing out, and there are 2 or 3 different types of pacemakers. And for the longest time, pacemakers were like sort of a contraindication for getting MRI scans. And so there are, in the past few years, it started around 2010. And since 2010, we have had these pacemakers called MRI conditional pacemakers. So, and then there are pacemakers that you use for correcting, people's heart failure sometimes. And so there are, and now.
So there's a really broad range of these things. So
yeah.
who needs, you mentioned earlier, people that have heartbeats that go from 70 per minute to 200 per minute. Are those the main group of folks that need pacemakers?
So the pacemaker is basically, they're only for people with slow heart rates. Pacemaker per se doesn't really correct fast heart rates. So there are 2 common group of people who get pacemakers. So one is, as I mentioned, they call sick sinus disease, meaning the sinus means there's a natural pacemaker that we have. It's a small piece of heart muscle that just beats continuous, and it's usually due to wear and tear for old age from the pacemaker. The second group of people is called heart block, meaning that the upper chamber electrical signals don't really go to the bottom chambers, and meaning like your upper chamber could be 100 beats a minute, whereas the bottom chamber can be only like 40 or 50. So you cannot really function very well, and that's called heart block. And those people need a pacemaker to support their bottom chamber. And so if you think about it, vast majority of the people get pacemakers for these two reasons. And there are some other groups too, but these are the two common ones.
Again, we're talking with Rakesh Gopinathannair, who is with the University of Louisville. He's the director of cardiac electrophysiology in the School of Medicine at U of L. We're talking about pacemakers. How many pacemakers does U of L implant every year?
Typically, I want to say 200 plus, 200, 250. And then there are other group of devices called defibrillators. So we implant same amount of those. And there are some fancy defibrillators for heart failure and all that kind of stuff. So I think around about that per year.
Okay. So you got several hundred per year just at the University of Louisville, and you probably have several others at hundreds more at other hospitals here in the Louisville area. So there are probably thousands of people in the Louisville area getting a pacemaker every year.
I would assume so, yes.
Is that a fair sentiment? So all of those people have heart rates that are low, correct? What causes that? Is it disease? Is it just a malfunction that they were born with? What is it?
So it's multiple reasons. One is that the number one reason is age-related sort of degeneration of your natural pacemaker. The secondly, you can also have, sometimes we may get heart attacks or, heart attack basically because of a blocked heart artery, you have muscle damage. And then sometimes it can also damage the electrical system of the heart. Then there are some people who get like open heart surgery. They had to fix a valve or something like that. And then some of these electrical wiring goes very close to these valves. So sometimes they can be damaged. And so that's another reason. And then if you have bad heart disease, like you have scar in the heart and then you have other issues, occasionally you can, consequent to that, you can get electrical system damage. And so those are the usual things. So it's a combination of age, underlying heart disease, plus minus what we do to the heart, so to speak.
How do we know? How do I know if I might need a pacemaker?
So let's say we walk a mile a day, and suddenly for the last week you said, "Oh, I can only do like a couple of blocks. I feel like I'm hitting the wall." That's one.
Really tired.
Tiredness, and then secondly, people say, I just walk and I feel lightheaded. And there are some people who may just pass out. And so some fatigue, exercise intolerance, dizzy spells, and, some rarely passing out. And those are signs that you might want to consider getting an ECG to check your heart rate.
All right, you've done this study and you've looked at a couple different kinds of pacemakers. What were the two different kinds you looked at, and what were you trying to figure out?
So currently, you have the two different kinds. One is a type of pacemaker that is labeled as MRI conditional, meaning that you can do an MRI scan.
MRI scan with the pacemaker in the body.
Yeah, okay. For the long time, patients were turned away from scanners because, you have a pacemaker, you can't do it. And so there's other group of pacemakers which are the old, what we call as legacy pacemakers or regular pacemakers, which are not labeled as MRI conditional. So when the MRI conditional pacemakers originally came out, there was a big price hike or delta associated with it per device. And so we wanted to kind of study, how many MRIs people get, and then we want to sort of project it over time as to what percentage of people may get an MRI. And then we also wanted to understand whether, let's say if you want a pacemaker, do you need to make a choice whether to get an older one versus MRI conditional? Is it really cost effective? And so that's kind of what we studied. So basically we had about close to 1,000 patients in a study that we sort of followed them for about 2.5 years to see how many of them got pacemakers. But in our study, these are all patients who were implanted with MRI conditional devices. And then
so those are newer ones, right?
Newer ones. And then we found that about close to 7% of them got MRIs in that time frame. So then what we did was we did some modeling to see, as the pacemaker usually lasts about 11, 12 years, or if it's sometimes even more. So you model and see let's say if you go the full lifetime of the pacemaker, what percentage of people get MRI. So we found that about close to 58% may need an MRI.
All right, so about half of them need an MRI over their life
over the lifetime of their first device. You can always replace the battery.
You can get a new one, right? So these are the newer devices. They last about 12 years, and over that lifespan of that device, about half the people need an MRI.
Absolutely,
and they can get one with these type of MRI devices, right? Okay.
Yeah, the average age of patients who get pacemakers is around 65 years, something in that range.
Okay.
So then what we did was we did something called as a cost effectiveness modeling. It's kind of more of a mathematical thing where you want to try to understand the incremental cost effectiveness for an MRI device compared to a non-MRI conditional pacemaker. And so based on the modeling, basically we want to find out how many dollars are you willing to spend to get one additional year of great quality of life. So that's kind of the way the cost effectiveness works. And so the $100,000 per one quality of life year is considered as less than $100,000 is considered as reasonably cost effective, basically.
Okay.
And so what we found in this study was that if you at about 7 years or so, when about 43% of patients will get MRIs, the device becomes cost effective. If you're only going to use it less than that, then it's not a cost effective endeavor.
How do you know if you're going to use it less than that? You might die.
It's possible. I mean, so this modeling included we adjust for death also. So
okay.
I think we adjust for mortality too. So that's where this 58% came from. And so we found that if you go the whole 11 years, you get $74,000. You pay $74,000 to get an extra additional quality of life year. So which is considered
that's a good deal.
Yeah, cost effective. And one other additional point is more recently, I also want to mention that the regular pacemakers you can do MRI provided there is a good protocol in your center. And CMS has most recently, CMS is Medicare, Medicaid. They have recently agreed to pay for MRIs in the legacy devices too. And so. Or more than that, because of the competition, the MRI device prices have come down too. So we did all that also in the modeling and found that even with the new regulations and everything, the MRI conditional devices were still very cost effective and roughly about $50,000 per quality of life year.
So what should I tell my doctor if I go to get a pacemaker and he says, yeah, you need a pacemaker? Should I tell him I want one of the MRI conditional ones?
I think I think that's what I would say.
So don't give me one of those old ones where I can't get an MRI.
This
right?
is not to say that we cannot get an MRI in an older pacemaker. You can, but the problem is that there are a lot of logistical, institutional, regulatory, and medical legal issues that needs to be sort of provide. Let's say I can go to my radiology department and say, see, look, CMS is going to pay for it, but they're going to say, oh, we don't have a protocol to do anything. I'm not.
Why? What's the problem with the old MR or with the old pacemakers? What potential health hazard is there if you get an MRI with one of the old pacemakers?
It's a great question. So basically there are two or three potentials. So the MRI is a magnetic field. It's also there is a radio frequency field, and the static magnetic and moving magnetic components can actually heat up the device. Ooh. Sometimes. It's very rare, but there's a potential. And then it can also deliver a static current through the wires into the wire tip is attached to the heart muscle, so you can actually heat up the heart muscle too. And it can also, in rare cases, can reset the whole circuitry of the device, and you'll kind of like shut down the whole thing, and then they call it.
That's not good.
And so those are they are very rare. I mean,
right,
I would say
1%
or less, because the older devices had a lot more sort of iron-related components that are more magnetic, and so when they designed the MRI conditional devices, they reduced those components so that you can safely perform MRIs, and that was the concern.
All right, so we need to wrap this up. So what would you tell folks out there that are just listening right now who think, maybe I felt a little sluggish the last few weeks, or they know someone who's felt a little sluggish? What would you tell them about going to their doctors, and also about what kind of pacemakers they ought to ask their doctors about?
I think if they are feeling symptoms like we talked about, tiredness and dizziness, etc., they should, they can check their pulse at home. They can, if they have an Apple Watch or something like that. If you think it's slow, you might want to go to the doctor to get an ECG, and sometimes you may need wear a heart monitor for a day or so to figure out what's going on. And if there is an indication for a pacemaker, there are certain, based on the slowness of the heart rhythm, and I would say getting an MRI conditional device would be the way to go. And again, this is not to say that you cannot perform an MRI on the legacy device, but I think it's much more simpler, easier, and I think and it's cost effective too.
Very good. Rakesh Gopinathannair, appreciate you being on the show.
Thank you very much.
Thanks a bunch. All right, after the break, we're in the midst of the worst drug overdose crisis in American history. Hundreds are dying every day from overdoses. Now the University of Louisville is pitching in to help Kentucky deal with the crisis and the shortage of doctors to do the autopsies on the bodies. You heard that right. We'll talk about it when we come back. You're listening to U of L Today with Mark Hebert on 93.9 The Ville. Welcome back to U of L Today with Mark Hebert on 93.9 The Ville. Well, you all know about the opioid crisis in Kentucky. You know there have been more deaths attributed to overdoses in the past couple of years. What you may not know is how the state of Kentucky's medical examiner's office is handling the increase in all those autopsies. Eyas Hattab is the chair of the Department of Pathology and Laboratory Sciences at U of L, and he has the answer in how U of L is helping out with this problem. Eyas, good to see you.
Great to see you, Mark. Thank you for having me.
All right, so U of L and UK have an interesting new agreement with the State Medical Examiner's Office. What's the agreement, and why do you have it?
Well, this is a new partnership, and it's just builds on a long relationship that we've had with the state. And what this entails is that the University of Louisville, as well as the University of Kentucky, will be hiring the medical examiners. These are pathologists, and that's where really they belong, is within the Department of Pathology.
And go ahead, finish it.
Yeah, and so under this agreement, we will be able to increase the pay for these physicians. We'll be able to offer them some perks that they don't currently have, and position the medical examiner to better recruit and retain.
And the reason the medical examiner's office in Kentucky came after this agreement and wanted some more doctors at U of L and UK was because we got a lot of folks dying, right? Because of the opioid
Unfortunately.
crisis. Is that what's going on? So what's the problem?
Well, this is a nationwide problem, and so you always hear about the opioid epidemics. This is a serious health issue, and it has resulted in a disproportionate number of overdose deaths since 1999. So today, in 2018, we have over 5 times the deaths that we've experienced in 1999. Just over the past 10 to 15 years, just the United States alone has lost over 500,000 people to the opioid epidemic. And so Kentucky is one of the hardest hit states. Unfortunately, we rank among the 5 worst states in this issue, and we have our share of burden when it comes to processing these deaths.
Yeah, and I think the note you sent me is Kentucky's rate for opioid deaths per 100,000 people is about double the national average or something like that. Is that right?
That's correct. So the national average is anywhere between 13 to 15 per 100,000 people, and we are more than double that. So we are at about 33 deaths per 100,000, and the majority of those deaths are related to the opioid epidemic.
And so the state medical examiner's office, are they required to do autopsies on every drug overdose death? Is that the reason that there's such a shortage of doctors and pathologists working in the medical examiner's office?
So the short answer is yes, and that's medical examiners process deaths that are outside hospitals or
Out of the ordinary? Or,
correct, that's right. And so that the most obvious are homicides and unexplained deaths, and yes, overdose deaths are or have to be processed by the medical examiner.
And so they've got a shortage, I assume, of folks, since these deaths, unfortunately, are piling up, these drug overdose deaths. They have a shortage of doctors and pathologists, so they've come to UK and U of L, right?
Yeah, and this is not unique to the state of Kentucky. Unfortunately, there is a national shortage for forensic pathologists. In the U.S., we only have about 500 of those, and there are just not enough of them to go around. And so this is, again, not unique to the state of Kentucky.
Right. Again, we're talking with Eyas Hattab, who's the chair of the Department of Pathology and Laboratory Sciences at the University of Louisville, and talking a little bit about the drug overdose epidemic in Kentucky and nationwide, and also what U of L is doing to help out the state medical examiner's office. So go back again and talk a little bit more in depth about this agreement with the medical examiner's office. What will U of L provide to the medical examiner's office, and what will the state of Kentucky provide to us?
So in essence, we are contracting the medical examiner services from the Justice Department. And so we will assume the hiring of medical examiners or forensic pathologists. So those will transition over to the university if they choose to. And
so they'll become employees of the University
they
of
will
Louisville?
become employees of the university, and they will the university will subsidize a significant portion of their salary. And so that will result in higher pay, but also hopefully better benefits to them and their families.
And they will be required to teach then, or do something else at U of L other than
Yes,
perform autopsies?
That's correct. So teaching is a major component of what forensic pathologists do in their current setting. So we train future pathologists, and those are residents and fellows. And forensic pathology is one aspect of their training. And so they do rotate at the medical examiner office, and the forensic pathologists are right now gratis faculty. So in essence, once they become employees, they will become full-time university faculty.
And U of L has agreed to supply how many folks to the medical examiner's office, and UK has agreed to supply how many folks to the medical examiner's office?
6 at UofL and up to 4 at UK.
And the reason we have more is because what?
Well, we are in Louisville, which is
City.
a bigger city, and there are 6 of them stationed here. And so, yes, the demand is much higher here.
What's a forensic pathologist? Easy for me to say. What is a forensic pathologist?
Well, a forensic pathologist is a physician who is trained in pathology and laboratory medicine that specializes in death investigations. And so, in essence, they are patients, if you will, patients advocates. And so they do autopsies with the attempt to uncover the cause and manner of death.
We're talking with Eyas Hattab, who is the chair of the Department of Pathology and Laboratory Sciences at the University of Louisville. And from what you're seeing in recent months and maybe years, is there anything that's been introduced into the opioid crisis that has made it worse, or has it gotten a little better in the last, few months?
Unfortunately, this has been getting significantly worse year after year. So there's been 3 waves, so to speak. The first wave started back in 1999 with the prescription opioids, and then there was a significant uptick in 2010, or the second wave, with illicit drugs like heroin. And then, unfortunately, the last 4 to 5 years with synthetic opioids, primarily fentanyl, that are produced illicitly. And so this epidemic continues to escalate out of proportions.
We've had Dr. Martin Hecker on the program a couple of times talking about fentanyl and heroin and opioids and the problems with all of those in the emergency room at the University of Louisville Hospital. Is there anything that you all have seen at U of L that has shown that we're moving in a fourth direction, that there's a fourth wave? In other words, is there something beyond fentanyl that's coming up that we should be wary of that perhaps is just now getting on the radar screens of doctors and pathologists?
Well, and one of the difficulties that ER physicians face is the notion that when a patient comes in, they don't really come in with a prescription saying, I have taken this drug or two. And what happens is that we're increasingly faced with new combinations of drugs that did not exist before. And that's really a huge challenge on treating physicians.
Now I'm going to ask you a really gross question, but I'm going to ask it anyways. If you're doing the autopsy on someone who has suffered an overdose of, say, fentanyl or heroin or an opioid, and what are you seeing as the doctor or as the person who's doing that autopsy? What are you seeing as the organs in the body or something that's been disrupted or damaged? What happens to the actual body when you do have a drug overdose? Is it the heart? Or does it affect different organs, or what happens?
Right. So if you are asking about the findings, the autopsy findings that are related to opioids, one of the difficulties behind drug overdoses in general is that there are often very few signs as to the nature of or the specific type of the drugs. And so that's where toxicology labs are important. So this requires extensive blood and urine work, and those come with an added expense to the state, and so this is why this is an expensive epidemic as well.
I mean, does like the heart blow up, the brain blow up? I mean, what happens when you have a drug overdose from a medical perspective?
Right. Again, it depends.
It
So
depends,
some of these patients present with extensive hemorrhages. They may be blue. They froth may be coming out of their mouths. Again, like you said, it depends how gross we want to get.
Last question for you. What's the counties in Kentucky that have been hit the hardest by this opioid epidemic? Is it Jefferson County? Is it Northern Kentucky? Is it Lexington? Where
unfortunately, this varies from time to time. Kenton County is the one that's been apparently hit.
Up in Northern Kentucky, next to Cincinnati.
Right.
Really?
Right. Yeah.
That surprises me because it's a fairly wealthy county. But I guess that doesn't matter, does it?
And unfortunately, yes, socioeconomic state does not appear to correlate very well.
Okay. Well, Eyas Hattab, appreciate you being on the show, and we'll look forward to greeting these new fellow employees we're going to have at the University of Louisville here.
My pleasure, Mark. Thank you for having me.
All right, we're going to wrap this up with a Did You Know segment. Did you know there are nearly 1,000 international students and scholars on campus, and more than 900 students study abroad each year at the University of Louisville? The International Center celebrates the benefits of international education through non-immigrant students and scholars, study abroad opportunities, student and faculty travel exchanges, and scholarships at the University of Louisville. That'll about do it for this edition of U of L Today with Mark Hebert on 93.9 The Ville. You can hear it every Monday and Tuesday night at 6 on 93.9. You can also listen to the podcast on SoundCloud and watch some of the programs on Metro TV or KETKY throughout the week. Check out all the U of L news, videos, and happenings at UofLnews.com. Thanks for listening, and go Cards.